Again, hello everyone and welcome to our first deep dive for the Pediatric Readiness Quality Collaborative. This call today is specifically for the disaster planning for a pediatric population intervention bundle. We'll begin with a couple of acknowledgments. The EMSC Innovation Improvement Center is supported by Health Resources and Services Administration of HHS. This information that will be described today, the content and the conclusions are those of the authors and members of the collaborative and should not be construed as the official policy or position of the entities that are listed here. For today's session, we are offering continuing nursing education credit as well as continuing medical education credit. We will ask that you sign up for those points by using the link that's listed here. We will also display this information at the end of the deep dive and also send out a reminder following today's session. The name of the learning session for today will be the Disaster Deep Dive. Today I am accompanied by Dr. Kate Remick and Diana Fingia, and we will be covering the following topics for the Disaster Bundle Deep Dive. There will be an overview of the Institute for Healthcare Improvement's collaborative model. We will spend some time discussing some common concepts for QI collaboratives, some of the support that we'll be providing for all of our affiliate sites. We will discuss the culture of the Pediatric Readiness Quality Collaborative, give a framework for the disaster bundle, and then really take a deep dive to look at the background, aim statement, change strategies, quality measures, and variables associated with the disaster bundle. And then at the end of the session, we'll have time to discuss next steps and housekeeping. So here you'll see a snapshot of the Institute for Healthcare Improvement's collaborative model, and you'll notice that the Pediatric Readiness Quality Collaborative definitely adheres to this strategy. And so what I'd like to do is spend some time really walking you all through this process. So at the beginning of the collaborative, the PRQC leaders identified a particular area or issue of concern. Then based on existing knowledge about the topic, we compiled a series of interventions or change strategies or improvement opportunities that would really help impact sort of the real world setting, sort of address any deficits that occur at a hospital or more importantly, patient care. Over the course of the last year and a half, we have recruited faculty members with a host of expertise in disaster planning, as well as clinicians who've demonstrated breakthrough performance in their own practice or healthcare setting. The PRQC team, along with these subject matter experts, have worked for the last, I'd say, year to provide specific content to the collaborative related to the aims, measurement strategies, and evidence-based changes. We have trainers from across the country working with teams to provide support and improvement methods and to help teams really apply these change strategies in their local areas. The enrollment of participants in organization and teams are really our affiliate sites. And so as of last October, we recruited 146 hospitals across the United States to participate in this Quality Improvement Collaborative. And so here today we start with our intervention bundles, or those development framework and change strategies. Over the next year and a half, we will have a series of face-to-face or in-person sessions for our trainers to ensure that they have the tools and resources to guide the affiliate teams. And then all of our affiliate sites will have the opportunity to participate in virtual learning sessions. And during this time, we will share content about best practices, review quality measures, and discuss any barriers that we exist over the next year and a half. There are a series of action periods, and within those action periods, we will do these things called PDSA cycles, or models for improvement will be the framework. And so we'll discuss that in detail within the next coming months. But one thing we want to stress is that some of the change strategies that you see today or the PDS cycles that we are going to discuss does not all need to happen within 1 month. They don't all need to happen within 2 months. We're asking that it's an iterative process, that you really think about some of these intervention strategies that you can implement that will have lasting impact on the care that you're providing. Some of the common concepts that we will cover will be aim statements, the model for improvement or PDSA cycles, quality measures and metrics, and then you'll hear us discuss a series of QI tools. So you'll hear concepts like key driver diagrams, workflows, process maps, SWOT analysis, fishbone diagrams, cause and effect diagrams. So one thing we definitely want to let our affiliate sites know is that you have support from our teams. That begins with the first level, which are your trainers. These are individuals that have committed to participating in the collaborative for the next year and a half. They will be providing mentorship to all of the affiliate sites that are on their team. And these individuals have expertise in pediatric emergency medicine, quality improvement, as well as emergency medical services for children. The next level of support that our affiliates will receive is formal QI education through the Institute for Healthcare Improvement's Open School program. So we have a license currently available, and we will be offering that to 2 champions at every affiliate site. And over the course of the collaborative, what we'll do is reinforce these concepts that you've learned within those QI modules. And we'll be sharing those best practices at intervention-specific webinars as well as learning sessions through December 2019. And then you will definitely receive emails from our team about new content and resources that are being available, that are published, or any webinars that are planned. So now I'd like to pass the mic to Kate, and she's going to talk about the PRQC culture.
Good morning or afternoon, everyone, depending on where you are in the United States, and welcome. Thanks for joining today. We talked a little bit about the culture previously in our first introductory webinar, but we want to mention it again because it's really critical that we all work together as a team, and that's really, the idea and the origin of the term that this is truly collaborative, with our goal really being to ensure that everybody has an opportunity to improve. So first and foremost, we don't measure our success by achieving necessarily all the metrics, but just by making improvements. And so as Crystal just spoke about with the iterative cycles, those PDSA cycles, with each step, we make a small improvement. And it's those moments of improvement that truly define success in the collaborative. There's no judgment here. We're all in it together. We're all here to help each other and support each other. But in order to do that, there really has to be a sharing of progress, a sharing of challenges. And we share that within our teams, within our trainers, and hopefully within the larger collaborative as a whole. And this is so that we can all learn from each other and help each other. Each of you will be part of developing innovation and best practices within your institution. And some of the models and methods that you develop will be very useful for others to also adopt and or to strategize around. And so we really stick to that mantra of we're all teaching and we're all learning. The other piece of that is this is really a grassroots effort. So everything that we're doing is really focused on what works at the front lines. And we know that each of you comes from a slightly different background and works at a slightly different institution. But yet we're all working together to make sure that children have access to the highest quality of care. And then the last thing that I'll speak about is just transparency. And transparency is really critical so that we can really see how we're all doing. And transparency isn't only important amongst each other, but it's also important for us as the administrative leads for this collaborative and for our subject matter experts to understand how folks are moving forward and the successes that they're having, and to be able to provide additional support as needed, additional talking points, additional tools or resources, whatever that might be. So we really do ask for transparency as we move forward. Crystal, if you'll go to the next slide, just talk a little bit about team meetings. And so the idea behind the team meetings is that this is an opportunity to really get into the weeds about some of the work that each of you are doing at your site, about meetings that you've held or interventions that you've planned and implemented. And these will be scheduled by the trainers depending on where you all are located geographically compared to where the trainers are. Some of these will occur virtually, some may occur in person, and some may be via teleconference with actual video capabilities. But this is a real opportunity to get to know each other and really work together. And we really hope that you do view yourselves as a team. This is part of the reason that we asked each of our trainers, hopefully in collaboration with you all as well, to come up with a team name, something that really speaks to who you all are conjointly. And so during these team meetings, the idea is to start discussing, what bundles you're working on, what you've decided to do, how buy-in is going within your local hospital, really to emphasize and reinforce some of those QI tools. And we'll be talking about these throughout. We don't expect any of you to understand all these tools now. We're going to start throwing out the names. You'll start to hear some of the language. As you jump into those IHI education series, you'll start to really get a better grasp of what we mean when we talk about each of these, and we'll continue to reinforce them throughout. And then finally, to really talk about your progress, and this includes really sharing how you're doing. We'll talk a little bit about data later on, but no individual site data will be shared with any other site by us. That is all your data for you to use and share as you like. But we do recommend that during these team meetings, you think about some confidentiality agreement. This is something very separate from DUA, but some kind of confidentiality that allows you all to really be transparent. That doesn't mean you're giving each other data. It just means you're sharing your progress and successes and barriers so that you can really work together and help each other. So at this juncture, I'm going to turn it over to Diana Finja, who's going to present the disaster bundle and our subject matter experts.
Good morning, everyone. Thank you again for joining us. As of Saturday, I received a copy of the disaster bundle, and hopefully you've taken a few minutes to at least scan through it to see what the contents are. And here we're seeing the table of contents. We're going to share some additional information on background, why disaster preparation plans that include children are important. We'll talk briefly about the aim statement, some of the domains of disaster preparedness. It's probably one of the bigger we are tackling here. How it seems to best be able to work with this particular bundle. We'll get into some of the quality variables that we will be collecting, and we will talk about the framework specifically with the domains. And then we'll talk about some disaster scenarios that have been developed for the actual tabletop exercises. The next slide, the resources. Next slide.
So I'm sorry, everyone. We understand Diana's phone is breaking up. What we're going to do is give her a second to make some adjustments, and then we'll continue with the next slide. You ready, Diana?
Yeah, let's see if this is going to work better. Can you hear me now?
Yes, we can. Go ahead.
All right. Some considerations that we probably need to take into our thought processes as we move forward. The intervention bundle, as it was designed for those sites participating in this particular collaborative. And as such, the content is still, we think it's pretty good, but we would dare say that it's probably not ready to be sold out on the market yet. You guys are helping us perfect it as we go through the process. As Kate said, we all teach and we all learn together. So we're sure that as we go through this process over the next year and a half, that we will find opportunities to improve. So it's not in its perfected form at this point. So it's just for us. If others reach out and would like to borrow it or utilize it with another facility, they will have to have special permission from the EMSC Innovation and Improvement Center. Part of the reason for this is that we know, as I said, it's not perfected, but hospital disaster plans are unique to each facility, each community, because we all have different that we are dealing with. And hence, hospital administrators and managers are encouraged to work closely with both your local teams in the facilities as well as regional and state healthcare systems so that your plans all link together. Can we go on to the next slide, please, Crystal? Okay. So at this point, I'd like to introduce some of our subject matter experts that we have been very, very fortunate to pull into this collaborative. Dr. Stephen Krug, he is Northwestern University Feinberg School of Medicine and Lurie Children's Hospital in Chicago, and he is the chairperson of the American Academy of Pediatrics Disaster Preparedness Advisory Council, and also sits on the National Preparedness Scientific Board with ASPR. So we're very fortunate to have him as part of our group. Dr. Brent Kasny is an assistant professor at Baylor and works in the section of emergency medicine at Texas Children's. He's the director of the MSC Innovation Improvement Center's Disaster Preparedness Domain. Matt Frost is the director of emergency services at Contra Costa Health Services and has been actively involved in California for many years, perfecting the disaster planning, and has a special interest in working with NICUs and the perinatal programs, making sure that they are prepared for disaster preparedness. And she actually sits on several national groups as well. Oscar Enriquez is an EMT. He is the Emergency Preparedness Coordinator at Dell Children's Medical Center of Central Texas and has received numerous awards and has received accolades of success from Joint Commission and others when they've gone through Dell, looking at their disaster preparedness programs and their disaster drills. So we're fortunate to have Oscar working with us as one of those down on the ground root people who can help us operationalize things. Laura Aird is the manager for disaster preparedness and response at the American Academy of Pediatrics, and she has been a wealth of knowledge and has brought many, many resources to this particular bundle. Brianna Smith works with Laura. She is the program coordinator for emergency readiness, and she too has been very instrumental in pulling many of the resources and keeping us up to date on new things that are coming out from the disaster committee at the AAP. Next slide. And at this time, I'm going to turn it back to Dr. Remick, who's going to give us some more background on why disaster plans are so important and why this is such an bundle and component of the Pediatric Readiness Project. Kate?
Thank you, Diana. And again, apologies if the audio was a bit faulty there. But we just really wanted to provide you all with a little bit of background of why disaster planning is so important, why we're doing this, and then we'll really dive into the elements of this bundle. So as all of you should be very aware of by now, is that with the 2013 National Pediatric Readiness Assessment that involved over 80% of hospitals, acute care hospitals across the U.S., over 50% self-reported that they did not have a disaster plan that included pediatric specific needs. So there's only some 46, almost 47% that did. And this is really a major problem, especially because we can never anticipate when and where a disaster might happen. And we know that it certainly involves all types of communities and locations. If you go to the next slide, we can also see that from that PEDS Ready assessment, that we know that those sites that have lower annual pediatric ED volumes were even less likely to have disaster plans in place. And so you can see the percentages across the different types of acute care hospitals or emergency departments, but certainly those sites that don't see children as often are much less likely to have a disaster plan that addresses their specific needs. Those that primarily focus on children, especially children's hospitals, of course, they're much more likely to have disaster plans that address pediatric specific needs. But surprisingly, even among the high volume sites, only 67% had disaster plans. So this is certainly an area of need and a place where we want to try to start and make a difference to make sure we're ready for everyone within our community. So if you go to the next slide, you'll see this is a quote from the 2006 Institute of Medicine report on the future of emergency care. And in this report, they stated that the U.S. emergency care system is poorly prepared for disasters as a whole. And certainly that there are deficiencies in day-to-day readiness, and those are only exacerbated during the setting of a disaster. This is why, disaster, of course, fits into the PEDS Ready model. We know that day-to-day pediatric readiness is somewhat of the foundation upon which disaster readiness occurs, but that these deficiencies occur broadly across the United States emergency care system. If you go to the next slide, Crystal, you'll see that this is just a timeline of some recent events, and of course this is not all of them, but it just demonstrates some of these events that we've seen in the United States over the last couple decades, starting with, of course, the World Trade Center tower bombing that we never would have expected, with more than 3,000 dead or missing. Hurricane Katrina, where we had more than 1,800 dead, thousands were sick and injured. We had the tornado outbreak in the plains, and that involved at least 345 people. Sandy Hook, which was of course predominantly children. The Boston Marathon, the tornado outbreaks across the Great Plains as well. And then, of course, more recently, Hurricane Harvey and Irma and Maria, and we're just beginning to get into hurricane season this year, and we know that we can expect more and more when it comes to both natural as well as man-made disasters. And so really every community, regardless, needs to be prepared. And I'll say even more so with the recent school shootings, just in 2018 alone, we're seeing on average one school shooting every week in the United States. And this is really something that impacts potentially every single community, even those that are in the rural areas. So if you'll go to the next slide, why is this particularly important for children? Well, children are absolutely disproportionately affected, and that's because of their physiology, it's because of their social emotional development and their understanding of these events. So we know that children tend to be lower to the ground. They're more prone to any kind of exposure to gases and things like that. They have more rapid breathing, so inhalation of any particular chemicals or products. Their skin is thinner. They're more prone to dehydration and heat loss. And so they're much more likely to be sickened or injured in the setting of disaster. The majority of children also require help from adults. We also know that when it comes to understanding of what's going on, these can be very stressful for children. They don't necessarily understand what's happening. They are not comfortable with new forms of communication. They don't necessarily know where to go or who to trust, and they require a lot more protection to be able to help support them. And unfortunately, the mental stress that can occur relative to a disaster is long-lasting and can occur for months and even years following the setting of the disaster. And so it's really important that we try to do our best to develop the infrastructure and the readiness to help support every child within our community and not to exclude children from our disaster plan. If you go to the next slide, there was a recent study that had come out looking at ED preparedness for children in the event of a mass casualty or a disaster. And this was done out of the state of Arkansas, and they looked at essentially 80 hospitals, and they received a 90% response rate. And they noted that only 13% of hospitals reported having a pediatric mass casualty protocol, and only 28% of those hospitals did the disaster plan even include pediatric specific issues. So this was even lower percentages than what we found in the PEDS Ready assessment. They found that most hospitals held mass casualty training events, about 94%, but only 64% of those reported including pediatric patients. So that's one of the key issues here, is making sure that PEDS are actually integrated into the everyday disaster drills and exercises. Most hospitals included public service entities like fire and law enforcement and EMS, but only about 23% actually included local schools and their disaster planning process. And this is particularly important when it comes to school shootings. And so this just highlights the needs that exist throughout the country in terms of disaster preparedness for children. If you go on to the next slide, in 2010, there was a National Commission on Children in Disasters. This was a report given to, at the time, President Obama and Congress. And in this report, they cited that there were persistent deficiencies in every functional area of pediatric disaster preparedness. And we'll talk about those functional areas. They noted that children were more often an afterthought than a priority, and that children, of course, were an at-risk, special needs, or more vulnerable population that needed additional support. If we go to the next slide, there was a follow-up in the Institute of Medicine. They conducted a workshop on preparedness, response, and recovery, specific considerations for children and families. And in this report, they highlighted 9 major events that occurred between October of 2012 and May of 2013. They cited approximately 176 fatalities, and this included 46 which were children, and so that makes about 26% of fatalities during that 9-month period were indeed children. And there were numerous near misses that they cited as well that could have increased those pediatric casualties. So at minimum, we should anticipate and expect that in any disaster or mass casualty event, that approximately 20% or 25% of those victims should be anticipated to be children. So if we go to the next slide, we're really happy and excited to know that through the recent hospital preparedness program, which is essentially a coalition building program on a national scale, directed out of ASPR, the Assistant Secretary for Preparedness and Response, as well as the Department of Health and Human Services. And this is a joint program to help develop disaster coalitions across the United States. And they, too, similar to the EMS for Children program, work towards achieving certain performance measures. And one of the ones that they most recently adopted is listed here, Performance Measure 22. And this is the percent of hospitals with an ED that are recognized through a statewide, territorial, or regional standardized system that are able to stabilize and or manage pediatric medical emergencies. And this is indeed exactly what pediatric readiness is. This is the exact same performance measure that exists within the EMSC program. And this speaks to the importance of day-to-day readiness as the foundation for pediatric disaster readiness. If you go to the next slide, what we'll be talking about throughout this bundle and referring back to is really a consensus-driven document that forms the basis for this particular intervention bundle. And this was a checklist that was developed in 2014 to help support every hospital in developing a disaster plan that includes pediatric-specific needs. And in this checklist, in this document, there are 10 domains that are focused on for pediatric-specific considerations. What you will find throughout the course of this collaborative that this particular intervention bundle focuses on the first 5 of these domains: coordination, surge capacity, coalition building, resources, triage, infection control, decontamination, and finally, family tracking and reunification. You will also see that this particular disaster bundle focuses on the use of disaster drills and exercises, which is listed here as domain 9. This is obviously a large checklist, and we know that there are such significant gaps that we wanted to start with some real foundational components of disaster planning. So if you'll go to the next slide, I'm going to go ahead and turn this back over to Crystal, who's going to talk a little bit about the aim statement for this disaster bundle.
Great, thanks, Kate. So we will start with our aim statement, and it is by December 2019, 100% of the sites that are implementing the disaster bundle will have a plan that addresses 4 essential domains of pediatric disaster preparedness. Those essential domains are disaster coordination, internal coalition building, surge capacity, and pediatric resources. Here you'll see the disaster domains that we will focus on for the first phase of the collaborative, and that is from September 1st, 2018 through December 2019. This phase 1 includes Domain 1, Pediatric Disaster Coordination, Domain 2, Coalition Building, Domain 3, Pediatric Surge Capacity, and Domain 4, Essential Pediatric Resources. Now here you'll see listed Domains 5 through 7. It's our intent to actually roll out the second half of that initiative in January 2019. So for phase 1, the best practice is that all sites should start with Domain 1 and then progress to Domain 4. We have no expectation that sites will complete all 7 domains. We realize that some sites have very minimal support and resources available, and so our subject matter experts felt that it was more appropriate to do a staged approach and start with the very basics. So our minimum expectation is that sites will complete Domain 1, which is Pediatric Disaster Coordination, and we'll discuss that in detail in a second. And as I mentioned earlier, phase 2 will be released January 2019 and specifically cover domains 5 through 7. And so now Kate is going to walk you through sort of that framework for each of those domains and sort of the major take-home point for those.
Great, thanks, Crystal. So what we try to do here is really just create a global map so that you can understand where all of these stick together. What I will say is that the disaster bundle is our largest bundle because there's so many components to disaster preparedness. But again, our focus here is just on small steps towards progress, and really our minimum expectation is to get through Domain 1. And that really speaks to pediatric readiness, which is integration of pediatric needs into the disaster plan. So you'll see in this map, it's divided into thirds. So phase 1 focuses on domains 1 through 4. Phase 2, as we mentioned, focuses on domains 5, 6, and 7, which will be rolled out in January of 2019. And then we have an optional regional pathway. We recognize that disaster planning starts locally, but certainly involves regional efforts. And for those of you that have the ability to engage in regional disaster planning, or who are working within a team that perhaps is all localized to one particular region, and this is an area of focus, then that regional planning may really make sense. And that really just depends on the buy-in and the engagement that you have in a particular location. So working through phase 1, when we start with this, really the disaster readiness starts with a disaster plan. So does your site have a disaster plan that includes children? And we'll be working through that, helping to develop some interventions that you can use to help foster the development of a plan that really includes children. If it does include children, then really the next step as well is, does your site have an emergency preparedness committee that includes both pediatric and ED representation? And we'll be helping you to really develop that and make sure that that is indeed also the case. In addition, if we move over to the left, moving down from the disaster plan, one of the next questions regarding that plan is, does that plan actually specify the percentage and age ranges of pediatric patients that would be involved in disaster drills? And during the last disaster drill, were pediatric patients indeed involved to the tune of what the disaster plan specifies? So those are some initial questions just to walk you through, and that's really some infrastructure pieces. Once a site has really progressed through that domain 1, which is making sure that there's pediatric representation, making sure that the plan includes pediatric, making sure that there's pediatric representation on the committee, then we can really get into the other domains. So domain 2 is really about local coalition building, making sure that all of the hospital departments or site-specific departments are engaged in disaster planning and drills. Domain 3 is looking at your internal surge capacity. That's both ED surge capacity, but also surgical capacity and inpatient resources to take and accept children in the setting of a disaster. And then domain 4 is really focused on pediatric equipment and resources. These 3 domains can be worked on simultaneously. They don't necessarily need to occur in sequence, but they may, and that's going to be site-specific. In January, like we said, we'll be working towards domains 5, 6, and 7, which speak to triage, decontamination, and family tracking and reunification. And then if you go over to the right, the regional pathway, this really starts to focus on those aspects. So for those sites that plan to engage their region in their work, first off is, does your site participate in a regional coalition? And if so, what's the level of regional engagement in disaster drills? That's the coalition building piece. And then the second piece is domain 3, which is, does your regional disaster coalition actually look at surge capacity within the region? What children can stay within that region, and what actual numbers can be accepted. So hopefully this just provides a general overview of where we're headed. And today, again, we're going to be talking around that middle third, really, which is phases 1, 2, 3, and 4. So if we go back to the next slide, just to focus on what those domains are. So pediatric disaster coordination. So this is really making sure that the disaster plan includes the needs of children and that there is a pediatric representative to help lead this effort. And that's to help lead that effort across all hospital departments, personnel, and leadership, and that all hazards plan indeed integrates the unique needs of children. Domain 2, which is our next slide, it speaks to coalition building. And again, starting locally, potentially working regionally as an optional effort. So first off, are all of the hospital, the internal departments engaged? Is there a coordination regarding communication and response in the setting of an immediate threat or disaster? And then secondly, within a regional state, is there coordination amongst public health, pre-hospital, hospital-based entities, as well as community stakeholders, such as shelters and schools and the like. Our next domain, the third domain, is about surge capacity. So again, starting locally, what is the inpatient surge capacity to be able to accept pediatric patients across all age ranges? So do we know what the inpatient bed capacity is for both infants and for older children? Do we have ED capabilities and surgical capabilities? And then expanding out into the regional domain, does the surge capacity integrate the regional disaster coalition so we identify where children can go in the setting of an all hazards threat? And then last is really speaking to essential pediatric resources, looking within our span of control, which is the local site. Do we have specific resources and supplies that we know are needed for children? This includes bedding, dietary needs, other particular care needs such as diapers and the like, and special medications or pharmaceuticals needed for the setting of disasters. And so that's just kind of an overview of these 4 domains. And then if we'll go to the next slide, you'll see how those all fit into that global map again, and where we'll be focusing on those first 4 domains. So at this point, I'll turn it back over to Crystal, and we'll start diving into the specifics of the disaster bundle.
Thanks, Kate. And as a reminder, if you have had an opportunity to download the bundle or view the email that was sent on Saturday with a PDF copy, it may be easier for you to sort of view the content with that bundle. But what we're going to do is walk you through each of the domains. Here you'll see this concept listed here, or this display as a key driver diagram. So when you're embarking on an improvement project, it's common to want to start with testing changes immediately. You have your aim statement, you want to achieve it, but how do you really know that the changes that you're making are really driving towards achieving your aim? And so here we have a key driver diagram, and it's really just a simple visual, sort of intuitive display to help you understand how you're reaching your aims. Here we have listed here that for the disaster bundle by December 2019, 100% of our sites will be implementing 100% of the sites that are implementing the disaster bundle will have a plan that addresses those 4 essential domains of pediatric preparedness. And here you'll see those 4 domains listed. Now, to get to those domains, or to the work that needs to be done, is that a disaster plan needs to be in place for domain 1. There needs to be some improvement strategies or some work related to key personnel, and education needs to be offered. For domain 2, which is coalition building, it really centers on team building. So some of the change strategies or ideas we have are based on team building. For domain 3, which is pediatric surge capacity, the areas of focus will be for infrastructure, so changes that you're making to the actual emergency department or where care is being provided. There will be improvement strategies related to education as well as stimulation. And then domain 4 is really about infrastructure. What are those essential pediatric resources that are needed to provide better care for our patients in time of disaster? So now what I'll do is walk you through each individual domain, 1 through 4, and we'll talk about the major sort of categories of change strategies. Now, I'll definitely start with this disclaimer to say your subject matter experts did not come up with an exhaustive list of interventions, but they highlighted some key areas that they thought would make the most impact with care. We are offering all the sites the opportunity to develop new change strategies as long as they fall into these specific buckets. So for domain 1, your sort of major areas of focus should be on the disaster plan, key personnel, and education. So your subject matter experts have decided that for the disaster plan, the first sort of improvement effort should be that you will work with your emergency preparedness coordinator and use the disaster checklist that Kate mentioned earlier to really develop your site disaster plan. In the event that you have a disaster plan that has been established, we ask that you do a second check. Look at the checklist that we've provided and see if there are some aspects that are not included in your current version. And what your first sort of improvement cycle could be is really integrating those pediatric-based components into your existing disaster plan. The second piece is that you should define the role and responsibilities of a pediatric disaster coordinator. And here you'll just see another snapshot of that checklist that we mentioned. It is currently available on our file sharing site, and you'll see that checklist, and you'll see that it's entitled Start Here, which is the perfect place to start when you're working on domain 1. Now, the second bucket of sort of interventions or change strategies for domain 1 are key personnel. And so it really starts with identifying an individual that has expertise or an interest in pediatrics and disaster planning. This could be a member of the care team, a physician, a nurse, nurse practitioner. We strongly encourage that the recruitment of this individual occurs in tandem with the emergency preparedness manager that's on site, and that you garner support from your ED and hospital leadership to empower that disaster representative. We're also saying that this individual needs to receive educational opportunities, and so you'll see a couple of recommendations here for educational opportunities that will help aid that individual with foundational knowledge and help them to do the job. And here under education, the change strategies are quite simple. You will develop a training or educational program for your care team based on the site's disaster policy. Now we're going to give you some help. So this disaster bundle that you see today may serve as the framework or the starting point for your education material. So we're actually going to send you the PowerPoint version instead of a PDF of this slide deck. And what you may decide to do is just copy and paste elements of your disaster plan and share that with the care team. Make that sort of the foundation piece for your education materials. Your education content should cover the following learning objectives, which are those 7 disaster planning domains. There should be some information about activating resources in time of disaster, and also what are the communication strategies that you use to activate your care teams in the time of a disaster. That training may be online, in person, staff meetings, or peer-to-peer. So PRQC will not dictate how training should occur for any aspect of the collaborative. What we say is do what works in your care setting. So if you have a learning management system similar to HealthStream, or if it's standard practice for your hospital to have brown bag sessions or luncheons specifically for the emergency department, maybe that's when you provide the education on the disaster plan. So we want you to really integrate what we're offering into your existing practices. And the other piece is, please remember to inform members of your care team about the role and responsibilities of that disaster coordinator that you've identified. Now what we're going to do is switch gears and start talking about Domain 2, which is coalition building. And there's only one bucket or one major area of focus for this particular domain, and it's all about team building. And so the change strategies are simple. We want you to compile a list of hospitals or departments that's clinical and non-clinical that should be supporting your disaster response. The PRQC will definitely give you a template of some of those entities that you should consider, and it's everything from the hospital leadership to housekeeping. And so that will be available on our file sharing site as well. You should be establishing some internal communication to relay information across hospital departments. You should also be compiling a list of regional, hospital, and non-hospital stakeholders, and this could be primary care, churches, medical homes, emergency medical services, schools, daycares, Red Cross, and begin a process for reaching out to your EMSC agencies as well as the operation managers in your region. The last two pieces are really about establishing a partnership with the relevant stakeholders, and that's your regional disaster coalition or the hospital preparedness program in your state, and develop an after-action plan for disaster drills. So now what we're going to do is move to Domain 3. There are three major categories of interventions for the pediatric surge capacity domain. Those three buckets are infrastructure, education, and simulation. So for the infrastructure piece, we realize that some hospitals have several resources and they have a lot of manpower. We realize that there are some on the opposite end of the spectrum. But you'll notice that our subject matter experts sort of considered what is sort of the basis or minimum sort of infrastructure that could be in place or enhancements that you can make to a system, and you'll see those listed here. And so we say that sites should consider developing a process or plan to measure, prioritize, and expand their pediatric surge capacity and capabilities based on resource availability. They should establish a process to determine which patients are transported to a particular location based on capacity, develop a process to augment the existing capacity, as well as create capacity by limiting elective appointments, procedures, and practicing surge discharge of patients that can be effectively moved to sort of non-hospital environments. The fourth element is that sites should develop a process to maximize conventional capacity as well as a plan for contingent capacity. So really adapting your patient care spaces to provide functionality equivalent of care, and then consider things about crisis capacity. So adapting the level of care that you can provide based on the resources when they're available or when resources are unavailable. And we are going to provide you, you'll notice on our file sharing site, a couple of tools that have been developed, for instance, at Rady Children's Hospital about surge capacity specifically, their policy, their guideline, their exercise drills for surge capacity. The next piece is that we ask that you define your pediatric transfer process, and this could be through the agreement and guidelines of how you facilitate the movement of your patients from a specialty facility or those patients that need more care during times of a disaster. And so we will be offering the PRQC's interfacility transfer bundle as a resource guide. And so that will be something that's released later this summer. And then lastly, some sites may decide to develop telemedicine or telephone consultation or agreements or some process or equipment to really facilitate the provision of that pediatric care in facilities that typically don't care for pediatric patients. And lastly, you'll see here, I'm sorry that's cut off, that we encourage sites to meet with their regional stakeholders and develop a method to integrate facility disaster policy on the community level as well as regional planning. So the next piece is education. So really think about education as how are we educating the care team about surge capacity. And here you'll see the learning objectives are quite simple. We want to find ways to ensure that we are adapting the patient care spaces based on the care that we are able to provide at that time, and also looking at adapting the level of care to the resources that are available when usual care is impossible. And so this may be one of the components that you include in your policy statement. When you're sharing it with your teams, you include how does the hospital handle disaster planning with respect to surge capacity. The other piece is that you should be informing the care team about the role and responsibilities of EMS and the staff during a disaster. Come up with some sort of internal communication strategy, be it text message, phone, visual displays. How are you going to communicate the process in collaboration with the team members during surge capacity or on surge capacity? And then really work with your coalition to discuss your external communications, timing, and process. The final sort of category for pediatric surge capacity is simulation. And so one of the very basis for this domain is that we are providing you with disaster scenarios that you can roll out at your site for disaster drills, and you'll see 6 of those listed here. And what we're doing is, so for the pediatric surge capacity domain, it may be best that your hospital actually does an exercise to see how well you're performing. And so we are encouraging sites that decide to really test their skills with tabletop exercises. And this could be a way to assess internal communication between hospital departments that are engaged. And it also is a way to work with your regional stakeholders that are engaged to see if there are any deficits that are occurring or any other opportunities for improvement. And so we realize that this is a lot of content that we just covered in the last 10 minutes, but we're going to have another session at the end of July that really tells you how do you operationalize these change strategies. How we'll provide workflows. So Dr. Brent Kasney has done some tremendous work with identifying workflows for each of these domains that are listed. And so we'll definitely give you some strategies for how do you mobilize and implement this disaster bundle. And lastly, what I'll show you is domain 4, and it's really about infrastructure. So we want you to develop a comprehensive list of pediatric supplies and medications that are needed in cases of disaster. Our website currently has a list of some of those essential resources. And it's also going to be important that you create source documents that outline sort of the location and constraints of those resources, and then create a checklist of resources and supplies that can be used during a disaster. And now I'll pass the mic back to Kate, and she's going to walk you through the quality measures and variables.
Thanks so much, Crystal. And just to reemphasize, as you know, Crystal went through all these different potential change strategies. It does not mean that you need to implement all of these. This is intended just as a guide, as a resource. Choose what works well in your care setting. And again, we'll be talking a little bit more about operationalization in the end of July, so in about a month, and we'll talk a little bit more about that. But please don't feel overwhelmed by all of these. We just want to try to provide as many resources to you all as possible so that you have a starting point and some strategies that you can choose from rather than having to develop your own, although some of you may develop some that aren't in this particular guidebook. So moving into quality measures. So, you know, more than 40 years ago, Donna Bidian developed a framework for looking at the quality of healthcare delivery. And when we talk about quality measures, we're talking about ways to measure improvement. So as the saying goes, that all improvement is change, but not all change is improvement. So when it comes to quality improvement efforts, we really need to have some measurement, some analytics, so that we can demonstrate that we're actually moving towards our aim, moving towards our goal. And so because of that, we have to come up with some kind of measures or metrics that we can utilize to demonstrate that we're moving towards that goal. And so what we've done here is to try to create quality measures within each of the domains that were discussed as part of the disaster planning process. And when we start with looking at quality measures, we start with structural measures. So this is really the foundation. This is just assessing really the availability of resources, the quality of those resources, the accessibility of those resources within a given area or domain. After we can move through structural processes, we then move into, or structural measures, excuse me, we then move into process-based measures. Process-based measures really speak to the delivery of healthcare services. So this is more specifically about the efficiency, the timeliness, the equitability of care that's being provided across a particular healthcare system. And then the last sort of level of quality is really the outcome measures. And certainly this is where we most want to get to. We want to look at how all of these structural and process measures actually impact the outcome. And this is the ultimate, which is, do we improve care? Do we improve more survival? And do we limit morbidity? And this is what we're ultimately working towards, but we have to start with the basics, which is really where PEDS readiness starts with, which is focused on those structural measures. So you'll see within this particular intervention bundle, because we're talking about disaster, we obviously can't get to real life situations to practice this. This isn't a day-to-day thing. We can't predict when these disasters are going to occur. But what we can focus on are the structural components and on the process-based components. And so you'll see with these measures as we work through, you'll see measures related to each of those specific areas. Within the other intervention bundles, as we deep dive into those, you'll see that we have indeed been able to integrate outcome-based measures, where we're actually looking at improvement in survivability, decrease in errors that are experienced by patients. But in this particular bundle, we'll really focus more on infrastructure and then on drills or exercises. So for domain 1, we have 3 structural measures that we've identified. These are fairly simple. So 1, does the disaster plan include pediatric specific needs? 2, does the plan outline the number of pediatric patients that should be involved in a drill? And 3, who is the pediatric representative on a hospital disaster committee? Is there a pediatric representative? And so when it comes to actual variables for data entry, there are going to be some site-specific variables and some exercise-specific variables. These are really site-specific. So these are the types of questions that we'd be asking so that we can help you monitor your performance and improvement. Has your hospital established a disaster plan? Yes or no? What domains are included in that disaster plan? And we're talking about the domains listed in that checklist and those domains that we've listed as part of this bundle. Does the disaster plan specify number of pediatric patients? And does it specify that there be a pediatric representative on the disaster committee? So pretty straightforward for domain 1. We move into domain 2. You'll see that here we have 2 structural measures and 2 process measures. So the structural measures, one is the emergency department participate in a regional disaster coalition. So this is a regional piece. And is there a catalog of entities that participate in the regional disaster coalition? As a second piece, we're actually looking at process-based measures. So when we get into coalition building within the local site, we can really look at those process measures. So using a disaster drill as your platform for looking at this, we can look at the percentage of internal departments that are actually mobilized during a disaster drill and the amount of time it takes to actually recruit them and to develop a disaster response. So that's process measure 2. And again, remember that those structural measures about the disaster coalition, those are optional measures depending on whether you choose to work on the regional piece. So in terms of the actual variables that we'll be trying to collect on this is, 1, easily, does your hospital participate in a disaster coalition and what entities are involved in that? The second is related to the internal coalition building, which is where we can get into those process metrics. So which departments are mobilized during a disaster drill, and how quickly can we mobilize them, so actually getting a timestamp for those. And we'll essentially have worksheets for you to utilize so that you can be documenting and following that to see how efficiently you're able to mobilize your site in the setting of a disaster. If you go to the next slide, we'll get into domain 3. So this is, again, pediatric surge capacity. So here we can really focus on process-based measures, which is how long does it take to really determine our surge capacity, because that's what we need to know in the setting of a disaster drill. We want to know how quickly we can do it. So in this case, time to determination of ED surge capacity, surgical surge capacity, and inpatient surge capacity. And this is all for meeting the needs of children across various age groups and across severity scales in terms of criticality. And so in terms of the variables that we'll actually be putting in related to this, if you go to the next slide, you'll see, does your regional disaster coalition have a mechanism, first off, to determine surge capacity? So that's regional optional measure. And then specific details about the internal surge capacity drills. So did we identify the care team needs in the emergency department? So this would be, how many physicians do we need? How many nurses do we need? How many techs do we need? How many beds do we have available so that we can determine our capacity to take in those children? What resources do we have in the surgical and inpatient services to meet the needs of those children in a particular disaster drill scenario? And then ultimately, this will be more moving into phase 2 when we start talking about triaging, but were we able to adequately triage the number of patients that should be triaged to our facility versus an alternative site or regional site? And then if you go to the next slide, which is our final domain for phase 1, which is essential resources. And again, using a drill as your prep platform, so exercising a drill at your site, how quickly are we able to determine the essential pediatric equipment and supplies that are needed to meet the needs of the children in that disaster drill? And so in terms of the variables entered, you'll see on the next slide, just the time to identifying those specific pieces of equipment and supplies. So these are really straightforward variables and measures that we're going to be looking at, straightforward data collection effort, and it all really depends on initiating a local drill. And then if you're able to or are hoping to participate in a regional drill or regional coalition building, then you can do that as well. So we're trying to provide as many opportunities for sites of all levels. We know that some sites may already have disaster plans in place, and others may just be getting started. And so this is intended to be able to be useful across all levels and all starting points. So of course, the data collection is important, and we know that you've all received emails from the University of Utah, which is where the National EMS for Children Data Analysis Resource Center is housed. We do need to make sure that we get those data use agreements in place so that we can provide you with the reporting and the performance results as we move forward through different cycles, through different plan, do, study, act cycles, as Crystal mentioned early on. The data portal has been in development for the last year, essentially. It's nearing completion. We will have a how-to guide that will be released later on this summer that will help you in terms of that data entry. It'll be a whole dictionary on what those variables are and what they mean to help guide you through that process. We'll also be shooting some webinars or videos that you can watch that will help guide you through the data submission piece. Each site, of course, has ownership of their own data. I mentioned this before. We will not be sharing any site-specific data with any other site, but we do strongly encourage you all to have as much transparency during your team meetings as possible. And then lastly, we will have some reporting dashboards available. So there will be different layers of dashboard or reporting. So each site will have access to their own specific dashboard. How they're doing in terms of entry, what cycle they're on, keeping track of their performance and measuring those metrics as we move forward. We will also have intervention-specific reporting. So for all the sites that are working on the disaster-specific bundle, you'll be able to benchmark yourselves against that aggregate so that you can see how you're doing and where you compare, just so you can get a sense of how things are going. That's also really important for us to be able to help guide and provide additional input, find additional resources, or make additional suggestions as needed. And then finally, we will have a comprehensive global PRQC reporting dashboard that will essentially be just reporting in aggregate on who all is involved and what bundles, not specific sites, but numbers. So, 50 sites, let's say, are involved in the disaster bundle, and we'll be able to demonstrate to the entire collaborative how folks are doing across the board. Of course, only in aggregate. There will be no site-specific data shared during that. But it's really nice to be able to see how you compare with one another, and so we're really excited to be able to work with our colleagues at NEDARC to make sure that you all have access to that. So at this point, I'm going to go ahead and turn it back over to Crystal, and I think we just have a few more talking points around this bundle.
Hey, Diana, you still here?
I am still here. Can you hear me?
Yes, go ahead.
Okay, we're a little bit better. We had to change phone systems here. I'm going to speak with you and share some information regarding resources that we've already put together and more resources that will be coming, and some exciting things from the AAP that they have recently developed that will also be available to those of you who decide to work on the disaster bundle. Our goal with the entire collaborative is to provide you with resources and expertise for each of the bundles so that you can progress and make improvements in your pediatric readiness. Each of the bundles will have some pre-readings recommended for them. The disaster bundle definitely has some pre-readings. One of them, Kate and Crystal both alluded to, the disaster checklist as a primary tool to help guide you as you move forward. I think as Kate was talking about essential equipment, one of the things that stood out to me is that that checklist has essential equipment that's needed for children during a disaster or even when hospitalized. And although your facility may not have all that equipment readily available, you need to know where you can get it quickly, and by quickly within a brief period of time. Do you have another hospital close by that carries that you can reach out to and access? That needs to be done in advance, not the day of the disaster, needless to say. So the checklist is a critical tool, and it sets up all of the domains so that you can see what's required in each of the domains. Important articles that are subject matter experts or tools that have been developed over the years will also be included in the folder inbox, which is your primary resource for right now for finding all of the resources, and the box site is there for you to log on to, and you'll see a disaster folder and resources, and as Crystal said, it even points you where to start. Start here. That folder will be updated periodically. We have folks who will be researching the literature to find new information that's out. And our hope is that as we learn from each of you, that we will also be able to, you'll identify resources that will be helpful to your colleagues. And we will be happy to post those in there as well. We also know that there will be educational webinars going on, and 2 new ones that the American Academy of Pediatrics and our colleagues over there have been working on will be coming up next week. The first one is going to be on surge capacity. That's on June 27th at 2 p.m. Eastern Standard Time, and there is registration required for that. And the link will be in the slides set for you to register for that so that you can participate. The second one will be coming up a few days later, and that one will be on family reunification, debut of a new AAP tool. That particular one will be extremely important when we get into phase 2 of disaster planning, and that one will be on that Friday. And again, these are both free, and you just need to register and attend. So we're excited that the American Academy of Pediatrics has worked hard on these, and they've actually got them out on time to help our participants in the PRQC so that you can get some things hot off the press. And we're very appreciative of our subject matter experts who have really gone out of their way to help make sure that resources are available to you. So please do access the box at that point. And I think we go back to Crystal for housekeeping now, if I'm not mistaken.
Thanks, Diana. So everyone, you'll also notice that we've just added a handout to the GoToWebinar platform that has the bundle that was released on Saturday. So if you are having trouble accessing our file sharing site, just expand the control panel for your GoToWebinar platform or your screen, and you'll see a section that has handouts, and you can download that Adobe PDF file. So action items. Your first step really will be about completing the Institute for Healthcare Improvement's Quality Improvement module. So we realize that some of our champions at our affiliate sites are brand new, novice to quality improvement, and so what we want to do is provide you with a very comprehensive tried and tested, validated QI education platform. And so that will be released on July 1st. You'll have your login, and you'll also receive a certificate of completion that you may want to use for your professional development. We are only going to be able to grant access to just 2 members of the PRQC affiliate team at that site. So more details will be following for that. Diana mentioned we have the AAP seminars, and so what we'll do is post today's slides on our website or on the file sharing site within the next hour so that you can download a copy of the links for the seminar, as well as the suggested readings will be available for your viewing. Administrative, the action item is really we need you guys to start working on your data use agreements if you haven't done so already. If you have not sent us the contact information for your hospital's designee, that's one of the first asks that we have for you, so we will be following up with you shortly about that contact information. And then there is one sort of major piece that we want to discuss with you guys up front, and it's this concept of an environmental scan. So we want to capture some information, sort of a baseline of where your hospital stands with respect to disaster planning and preparedness. And so this environmental scan is a series of questions that we will ask about the status of your program, and that's something that's going to be due on July 31st, and we will release it on the July 1st. So you have about a month to complete that 20-question survey. And if you haven't had your site visit, please let us know. If you have not completed your site visit 1 survey, please do that as soon as possible. And these are the important dates to keep in mind. So on July 1st, we have put together sort of anticipated completion of the data use agreement process. The link for the environmental scan and the process for registering for QI education for those 2 champions will be released on July 1st. On July 31st, that's the deadline for your environmental scan. On July 31st, we are going to host another disaster deep dive, and really Diana called it the recipe for success. How do you actually operationalize this bundle? So today we gave you the foundational content. On July 31st, we will really go into workflows, the data process to really get you started, because remember, September 1, we go live. So these are some important dates to keep in mind. And yes, the environmental scan is only for those sites that are participating on a particular bundle. So each bundle, and I'll show you a snapshot of this, each intervention bundle actually has an environmental scan, but they are very different for each bundle. And so we'll be releasing those following the deep dives. So here you'll see the release date. So the next bundle that we will discuss will be on June 26th, and we will release those bundles on Friday, June 22nd. The next bundle after that will be interfacility transfers, which will be on July 10th, and then weight and kilos will be on July 17th. And as I mentioned earlier, the disaster bundle part 2 will be on July 31st. I will be sending an invite for that one. It's going to be a mass invite, so it's going to go to everyone in the collaborative. That session will be recorded if you're unable to attend, along with slides. And we are going to provide all the sites with sort of a mobilization packet or an implementation guideline that walks you through the entire process from A to Z on how do you convene a improvement team at your local site to really help you do this work, all the way to what the data requirements are for the collaborative. So just keep these dates in mind. And then lastly, CNE and CME credits. So we really are happy that we had about 117 folks on the webinar today. And so we want to offer you CNE and CME credit. Here's the link. You'll also see it listed in the chat box. If you click on the message from myself, you can complete the survey and list Disaster Deep Dive as today's learning session, the name of today's learning session. And so now what I'll do is I'll open it up for questions and answers. We have about 10 minutes remaining. I'd encourage you to use the chat function and submit your questions to the entire group. Kate, Diana, and myself will try our best to answer your responses. And I'll start with our first question, which came in. Can you give us an estimate of the amount of time per week that would be needed to roll out this bundle? And so we're estimating that no more than 2 to 4 hours should be dedicated each week for any of our bundles. Resources will be given to provide for educational talking points, and we'll provide you with a lot of the resources that you need. So some of the groundwork will be done for you. And really it's going to be about garnering support from your ED hospital leadership. But then some of these will require infrastructure changes, which we'll do over time. So we're not expecting that you will complete your first domain from September 1st to October 1st. That would be great, but we want you to be realistic and take your time and really be thoughtful in the content that you're creating, because the goal is to sustain these improvement efforts over time. So we'll definitely give you a process to help guide you through those week-to-weeks for the first couple months. And so we're expecting about 2 to 4 hours every week. Any other questions? Kate, Diana, any feedback or best practices you'd like to share with the group?
Sure. I'd just say, this was a lot of information for you all. Please just remember this is intended as a resource, and really the goal is just to take it slow. If you choose to work on this bundle, just remember that the focus here is just starting with the basics of having a plan in place and making sure that kids are included in that plan. So try not to get too lost in the weeds of it, and we will help guide you every step of the way working through this bundle. And something that we didn't mention on this particular call, but we did mention earlier on the initial call, is that each site will have an opportunity to work through more than one given bundle. So you may choose initially to start with this bundle and realize that you can't really get past domain 1, and that's fine. You're welcome to begin to think about other bundles, or you're welcome to start with one of the other bundles and then join this bundle later on, or start work on this, several months into the collaborative. So every site is working at their own pace, and we're just here to provide support to each of you throughout the process.
And I would comment to the group that that whole culture of collaborative, the transparency piece, identifying when you're having challenges, that's why you're on a team. I assure you that there's other folks on your team who are also struggling to a point, maybe with the very same issues. And by having colleagues who can work together on those challenges, hopefully you can find a resolution. And you all are linked with training sites that have just excellent, excellent resources within them. So between them, between each other, and between the resources that we provide, we anticipate that everybody's going to have some successes, maybe not to the extent that you would like entirely, but the reality of it is you will be making progress, and we'll be delighted to celebrate those progresses with you. So we're glad you're here, and we're glad that you're interested, because together we can make a difference for the emergency care of kids, especially in the realm of pediatric readiness, and in this situation, disaster preparedness, which is so sorely lacking across this country for kids.
So as a clarification, we just received another question, and it's just to clarify, are we able to work on more than one bundle at a time? And do we need to finish one, then go to another one? Kate, do you want to take it, or you want me to take that one?
Sure, I can take it.
Okay.
So you are able to work on more than one bundle at a time, although we're asking that each site start with only one, just to get a feel for this process and how this collaborative works. But as you begin to move forward, you are absolutely welcome to work on more than one at a time. You may end up working on them in sequence or simultaneously. It really just depends on you and on your site and on the buy-in and the success that you have. So as well as the time that you have to put into each of these. So hopefully that answers the question.
We have about 5 minutes remaining, and we're certain that folks want to attend their next call or meeting on time. Any other questions before we end today's session?
Thank you all so much for your time today. If you do have any follow-up questions, please feel free to reach out to us directly. Also, of course, your trainers. If you have not been in touch with your trainers, please let us know. It's really important that the team structure is functional and effective. So we would like to hear from you. And hopefully we will see you all back on the call, at least on July 31st, if not sooner, with the various other intervention bundles on June 22nd or 26th and so on. So thank you all for joining today. Much appreciated.